Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of June 2nd, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. After an update on contagious illnesses, I will try to make some sense out of new and confusing guidance regarding COVID vaccines. First, taking a look at respiratory viruses among patients presenting to a healthcare setting for testing. As of May 24th, the largest share of cases by far is made up of rhinovirus enterovirus, which is represented there in the gray line. And we see that that has been increasing, an increasing share of cases for the past couple of months as flu, which is in that bright blue line, has come down. And then to a much lesser extent, we're seeing para-influenza virus that is represented in the yellow line and then followed by human metapneumovirus in the black. SARS-CoV-2 in the red is coming in at number 4, even though I think it is safe to assume that a large proportion of those who get SARS-CoV-2 are finding out on a rapid test that is not reported, and so therefore wouldn't be reflected here. And as we lose access to free home COVID tests, and presumably fewer and fewer people are spending money on what are pretty expensive rapid COVID tests, this may become more representative over time. But until then, we continue to look at other earlier indicators to give us an idea of where we are with COVID. And important to point out that this is obviously the United States on average. And so especially as we start heading into the summer months where we have historically had increases, it's going to be important to look at the different regions because this is going to vary depending on where you are. And one of those early indicators is, of course, wastewater. SARS-CoV-2 in the wastewater is considered very low nationwide. In the Western region, which is in that teal color, it is considered low, which is more than very low, and increasing. So Western region already starting to increase, so we'll just keep an eye on things as we go along. And when we look at the map of COVID epidemic trends, and remember this uses modeling based upon emergency department visits to see what direction things seem to be heading. And we do see some places that are thought to be increasing. That is shown in the darker purple. And so that would be Florida and Washington at this time. And in the lighter purple, it is likely growing. And that would be California, Tennessee, North Carolina, and Massachusetts. Now, 2 weeks ago, when I reported, Nevada and Hawaii were both likely growing, and now they appear to be declining. So I hope that means that they're done for the summer, but definitely remains to be seen. And now taking a look at hospitalizations and deaths. So on the left there is hospitalizations, and we can see that flu in the blue continues to decline as expected for this time of year. And on the right-hand side, you can see deaths, and we can see also that the blue is starting to get to be a smaller and smaller share of deaths, whereas COVID hospitalizations represented in orange on the left, COVID deaths represented in orange on the right. And in both cases, they're more or less steady, maybe declining just a little bit. But of course, they're making up a bigger share now of hospitalizations and deaths as RSV and flu predictably come down to negligible. And in terms of US COVID deaths, there have been 267 COVID deaths recorded so far for the week ending May 3rd. And we know we might get a few more straggling death certificates that come in and get added, but it's usually just a few. And so I wanted to point out that this looks to be very significant. This is actually the first week since the onset of the pandemic that we have had fewer than 300 people die of COVID. So this is an all-time low since March of 2020. So still 267 people dying in a week is still too many. Also, being that it is a low point, I think the real question is where will it go from here? Last summer, we obviously had a very significant summer wave, and so we just want to keep an eye on this as we move along. Now I'm going to share kind of this blast from the past. We haven't had to look at this for quite some time, but this is just to get us reacclimated. And this is the variant tracker that we have reformatted here to make it a little bit easier to look at. The top two bars represent actual variants that were detected on United States patient specimens in the second half of April. And the bottom two are estimates based on forecasting. And what the forecast is telling us is that we're pretty much dealing with the same variants we've been dealing with for quite some time, primarily LP.8.1 in the orange, and XEC in the green, and XFC in the brown, which looks to be increasing the most significantly. Nothing too exciting here, but I'm getting us reacclimated just in preparation for the possibility that a new variant, which is called NB.1.8.1, may be making its way on the scene. The World Health Organization Technical Advisory Group on Virus Evolution has designated NB.1.8.1 as a variant under monitoring. So they are saying that it is somewhat more immune evasive than the LP.8.1 we were just looking at, and its proportions do seem to be growing rapidly worldwide. So once this variant reaches more than 1% of specimens in the United States, then we'll see it show up on our tracker. But so far, there doesn't seem to be any major cause for alarm, with the caveat that we still need more study in order to really quantify how much better this variant is at getting around our prior immunity. But in the meantime, it does look like this variant is still susceptible to Paxlovid, as well as the immune response we get to the current COVID-19 vaccines, although we see that it is somewhat getting around that. And as a reminder, the FDA's advisory committee has recommended that for the 2025-26 season, that we stick with the same vaccine formulation from last year. So this is significant. This is actually the first time since we've started doing this that there will not be an update to the vaccine for the season. But like I say, thankfully, it's been a while since we've had to even talk about variants. But when we do have to talk about them, this is one of the rare times that I will refer to a preprint, and specifically from Young Long Cow's lab, because they have been performing this amazing work for much of the pandemic where they are characterizing the different variants as they emerge. I've linked this preprint in the post. It's about a few different variants that have been emerging, but it did specifically note some of the advantages that NB.1.8.1 has, including that it latches on very well to our ACE2 receptors. And it also does a good job of getting around our prior immunity, and I quote, supporting its potential for future dominance. So of course, this all remains to be seen. So we will see what we see, and we'll continue to update on that as we go forward. Now for a brief update on U.S. measles situation. As of May 30th, there are 1,088 confirmed cases, and this is up from 1,024 when I reported 2 weeks ago. Last year, for the entire year, 2024, there were 285 cases. So already in 2025, we're not even halfway through, and we're getting close to 4 times the number of cases that we saw for the entire year of 2024. And we know that the largest outbreak so far began in West Texas, but there have been several other outbreaks across the US. Recently, there were 6 cases linked to a flight that landed at the Denver International Airport in mid-May. 4 of the individuals who got measles were on the plane, and 2 others were exposed at the airport. And I think it's important to note that there's an outbreak not only in the United States, but also in Mexico, as well as Canada, where they've confirmed over 2,500 cases. We've had some cases pop up here in California, but since California has excellent vaccination rates, it's much less likely to go beyond households and very close contacts to create major outbreaks like what we're seeing in West Texas, of course, unless it hits a pocket where there are low vaccination rates. But having said that, it is becoming an increasing concern everywhere, as vaccination rates continue to decline in many different areas across the United States and beyond. And I think this recent outbreak in Denver presents an important wake-up call for anyone who is traveling, especially anyone who's traveling. So airplanes, airports, these are high-risk locations with a lot of mixing from all over the world. Wearing a high-quality filtration mask is an important layer of protection. Of course, in this case, the most important layer of protection is going to be the highly effective vaccine. So if you're not protected from measles, either by having previously survived measles or through the 2-dose vaccine series, then this is something really important to do in general, but especially before traveling. The 2 doses are given 28 days apart, and then it takes another couple of weeks before you build up your immunity fully. So that's 6 weeks. So please get to planning if this applies to you. We can now give the vaccine as young as 6 months of age. In that case, it would just be the 1 dose. So at least 2 weeks before traveling with your infant of 6 months or above. Thus far, 133 individuals have been hospitalized. There have been 3 deaths, 2 little girls and 1 adult. And there have been other deaths as well in Mexico and beyond. And 90% of the cases in the United States so far are outbreak associated. By comparison, in 2024, only 69% were outbreak associated. Now I want to touch on recent developments and the resulting confusion regarding COVID vaccines. So on May 27th, Health and Human Services Secretary Robert Kennedy Jr. announced that COVID vaccines would no longer be recommended for healthy children and pregnant women, and that the vaccines were being removed from the CDC recommended immunization schedule for the groups. He cited no actual evidence for this position, just said that it was common sense and good science without providing any common sense or good science. Following the announcement, the CDC did in fact update its guidance, but what they came out with is a lot different than what RFK Jr. announced. The main thing the CDC did was change the should to a may. So healthy kids and healthy pregnant women may get a COVID-19 vaccine and instead of should. And CDC still encourages individuals to talk with their healthcare provider about any personal medical decision, of course. So a few things about this. As far as the science is concerned, nothing has changed. These groups still should get the vaccine. The vaccines prevent severe illness and death, including in children, including in pregnancy. In fact, all the leading medical organizations, including the American College of Obstetrics and Gynecology and the Society for Maternal and Fetal Medicine, have strongly pushed back against removing the vaccine recommendation. They are emphasizing that the science regarding COVID and pregnancy has not changed. We know that pregnant individuals are at higher risk for severe illness and hospitalizations and complications from COVID. This includes preterm labor, preeclampsia, and even death. Vaccine preventable death. Not only is COVID vaccine safe during pregnancy, but it protects both the pregnant person and the newborn through what we call passive immunity. So it passes right on to the baby. And this protects baby for those first vulnerable months of life. You might remember me sharing this information when I reviewed the presentations at the last Advisory Committee on Immunizations Practices meeting. But the bottom line here is that COVID's seriousness for children, especially under 6 months old, is really shamefully under-recognized and is obviously being minimized by these new developments. So while we know that those over 75 have the highest hospitalization rates, you can see here that infants under 6 months of age are the next most impacted group, followed closely behind by the 65 to 74-year-olds. So please let that sink in. COVID hospitalization rates for 6 months old and younger are on par with our 65 to 74-year-olds. This hospitalization data alone should concern us all. And it highlights the importance of maternal COVID vaccination to protect these infants. It is really important that pregnant individuals be made aware of these risks so that they can make informed decisions for themselves and their babies, because unfortunately, the messaging that they're getting now is creating confusion. And it's not only the babies that we're worried about or the pregnant women that we're worried about. Children of all ages can be severely impacted by COVID. We've already had hundreds of thousands of hospitalizations, thousands of deaths. It's a leading cause of death, even among children, and even among children with no underlying conditions. There is no other vaccine preventable cause of death of this magnitude where we just shrug our shoulders and say, oh, you may get the vaccine. No, we tell the truth and we say that they should get the vaccine. So there's clearly a big discrepancy between the Secretary's definitive statement and what actual scientists and experts are saying. And there's also clearly a discrepancy between the Secretary's definitive statement and even what the CDC came out with, which is a much more subtle adjustment to its website. When the head of HHS makes a definitive public statement without evidence that contradicts scientific consensus and the advice of the CDC, it creates a very powerful mixed message. And for a lot of people, that's all they're going to hear. All they will hear is the Secretary's pronouncement, and maybe that's the point. A couple of other things, it was a very abrupt change, even the nuanced change to the CDC's website. It was made without the usual transparent public health advisory committee process, and this in and of itself is very concerning. So the Secretary's announcement and the changes on the CDC website appear to have circumvented the usual process. This is really unusual and very problematic, because they can keep saying the word transparency as much as they want, but this is the exact opposite of transparency. And we know that when you have such a high level pronouncements like this, especially when they're not aligned with scientific consensus, this can easily be exploited and amplified by those who spread misinformation and disinformation, further muddying the waters and making it harder for people to make informed health decisions, especially when we know we already have people who are maybe not enthusiastic or even hesitant or just confused. They could definitely interpret all of this as an official signal that the vaccines are no longer necessary for these groups and beyond. And we know that that is far from the truth. So the damage is really, I think, significant. It's also possible that if the vaccine isn't on the routinely recommended schedule for certain groups, that insurance companies might no longer cover the vaccine for those groups. And if that were not bad enough, the proposed cuts to Medicaid that are on the table threaten to kick millions of people off of their coverage. So I'm not going to go too far into the proposed changes today, because I'm truly hopeful that most of them will not come to pass. But this is a really critical intersection of policy changes with potentially very devastating consequences. And I just want to add to the apparent inconsistencies and guidance coming from the top. There is a recent FDA approval of a new Moderna vaccine, next spike. So over the weekend, FDA approved Moderna's new COVID-19 vaccine, branded next spike. We were calling it mRNA-1283 before. This is a so-called next generation vaccine. So it's not just an updated version of their original. This is next generation. And I went into some detail when I reviewed the ACIP meeting, but in brief, it targets specific parts of the SARS-CoV-2 spike protein. So the parts shown here, the receptor binding domain and the N-terminal domain, these are thought to really elicit the most effective antibodies. It's also, this allows for a lower dose. So it's 1/5 of the size of the original Moderna vaccine. So this could be good news for people who found it kind of reactive. And its clinical trials showed that it was at least as effective as the original Spikevax, and even more so by certain measures, and especially in older adults. It also seems that this version might be refrigerator stable, so that will make it easier to store and to distribute. And Moderna expects next spike to be available for the 2025-26 respiratory virus season. So in general, I think this is good news, but I want to point out a couple things. First, this COVID vaccine has only limited approval. So it's approved for all adults age 65 and up, and those 12 to 64 with at least one medical condition that increases their risk of a serious outcome from COVID. And you might recall that Novavax, which I reviewed not too long ago, also recently got limited approval with similar restrictions. So even though we hear all these platitudes about freedom and choice, it appears that with everything I've just reviewed, freedom and choice are actually being systematically limited and restricted. The other thing I wanted to point out is what appears to be a significant departure from the regular process. So usually what happens is the FDA evaluates the safety and efficacy of new drugs, new vaccines, based on scientific data for specific indications. Then it's the CDC that makes the recommendations for public health practice. And they base that on a number of things, the overall benefit and risk and population factors. But this has not appeared to be the case lately. And where the FDA is the one just coming out with both the approval and the recommendations for the indications. So this is concerning. It at least seems to reflect a disconnect in the current administration's messaging and priorities. So, like I said, approval of a new potentially better vaccine for high-risk groups is a positive development, but it does not erase the confusion caused by de-emphasizing the importance of vaccines for other groups, circumventing established processes, and so on. So this seems like a lot of conflicting signals. On the one hand, you have HHS Secretary de-emphasizing COVID vaccines for healthy pregnant people and children. On the other hand, they're approving a new vaccine, signaling that they recognize the need for protection for vulnerable populations. So this is extremely fragmented public health messaging. And I think it's more than just a communications issue, even though we do know that reductions in force have wiped out communications departments in many areas of the federal government, which I've reported on here before. But I think it's more than that. Many of us are concerned that this contradictory messaging from high-level officials and the change in CDC recommendations are going to lead to decreased trust in public health, people not knowing who to believe, what to believe, which guidance to follow. But ultimately, it will lead to reduced vaccine uptake altogether. People, especially those who are on the fence, may now decide against the vaccine for themselves or their children. And it's really challenging to watch this. Instead of transparent, expert-led processes like those ACIP meetings, we're being subjected to these top-down announcements that are broad and vague and inaccurate. They're not based on any kind of data, any kind of science. So it leads us to believe that they're more politically or ideologically motivated, and we deserve better than that. Without consistency and transparency and scientific consensus, what do we really have left in terms of public health and public health communication? And just to reiterate the concern about insurance coverage issues, if vaccines are not routinely recommended, insurance coverage could become a significant barrier. And all of this is a setup for increased illness, increased severe outcomes. Fewer people, especially those at high risk, our pregnant folks, our babies are left unprotected, our children, the importance of them being protected gets minimized. This could just lead to more COVID cases and hospitalizations and death. So I think the best thing we can do is continue to stay informed and to advocate for maintaining access to information and to vaccination and to care. If you don't feel well, take at least two COVID tests 24 to 48 hours apart to rule out COVID. If you're positive and at risk of a bad outcome, quickly get in touch with your primary care provider to get treatment. If you don't have a primary care provider, please get one, develop a relationship with them, make a COVID treatment plan if appropriate. And just in general, make sure you're getting the appropriate labs and screenings and vaccines based on your age and risk factor. Believe me, all these folks in the highest levels of government with all these top-down recommendations, they have access to the best primary care, and you deserve it too. And try to eat a balanced diet, try to manage your stress levels, let's stay well hydrated, quit smoking, avoid alcohol and simple sugars and processed foods and artificial ingredients. And if you don't feel well, please make sure you get your rest. Otherwise, get some physical activities, get some fresh air, and again, manage those stress levels these days and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us. We'll see you next Tuesday at 10 a.m.